tonight, if you have to resuscitate a patient on ECMO and the pressure is 40/20 and blood is hitting the ceiling, what should you do?
Welcome back to PedsCrit. I'm Zach Hodges.
And I'm Alice Shanklin. And today, we're coming in for part 2 of our transfusion medicine episode with Dr. Phil Spinella.
Dr. Phil Spinella is a professor in the departments of surgery and critical care medicine at the University of Pittsburgh. In addition to many other leadership roles in transfusion medicine, he is the director of the Trauma and Transfusion Medicine Research Center at the University of Pittsburgh. He also co-founded the THOR Network for Trauma and Hemostasis Research. It's also been involved in multiple nationally funded research programs.
Yes, we are so excited to have him back for part 2, where we really talk about not only what is the cutting edge of transfusion medicine in 2025, but also specifically what's going on with the temperature of platelets, how should we be thinking about plasma for volume expansion, and really what's next in transfusion medicine research.
Such an exciting topic with many more updates to come. Let's jump right to the conversation.
Dr. Spinella, we've been talking with you about use of whole blood in the military during those high-risk resuscitations. I'd love to transition here through the early 2000s to present day that we've started to shift transfusion practice in civilian life. Can you talk to us about really the landscape here?
Yes. Over the past, maybe 15 to 10 years, there's been a transition in actually even just applying hemostatic resuscitation. The term hemostatic resuscitation is meant to describe the practice of a blood-based resuscitation for bleeding instead of a crystalloid-based. Those of us who are a little bit older, who trained 25 years ago, were taught to start with crystalloids, then after, in an adult, 2 liters of fluids, then start using red cells. And if that's not working, do some lab tests. And see if you need plasma, see if you need platelets. All those lab tests come back an hour later, right? And then in that era, we had a mortality in the 40-50% range for patients with life-threatening bleeding. The experience in Baghdad kind of taught us that was an inappropriate approach, and a blood-based resuscitation has kind of taken us down to a 15 to 20% mortality risk when used. So this concept has been clearly catching on in the adult trauma world. I would say it's becoming standard that whole blood is used at trauma centers. There was a publication in the THOR supplement in Transfusion last year that from 2021 data, that there are over 300 trauma centers using whole blood in the U.S. today. 2021 data. So we expect that number is probably in the 350, maybe even 400 trauma center range today in 2025. Pediatric hospitals have been a little bit slower to adopt whole blood for trauma. There are multiple reasons for that, but there were at least 11 to 12 pediatric trauma centers using whole blood as their standard practice before we started our MEDIC-2 trial of whole blood. So whole blood is definitely becoming incorporated into standard clinical practice for trauma. Now, what about non-trauma? Right, in the adult world, whole blood is being used. It's been hard to survey this as the number of centers has gone up. But roughly a third of the trauma centers using whole blood for trauma or using it outside trauma. If you have an MTP activation from a GI bleed and the patient is hypotensive, has life-threatening bleeding, there are centers using whole blood for that MTP for GI bleed or postpartum hemorrhage, right? Or cardiac surgery patient who has life-threatening bleeding. And there's even a few children's hospitals that are doing that too. Here in Pittsburgh, we changed our MTP policy to use whole blood for any child with an MTP activation. So you have a kid on ECMO, right? Yeah. Who has this catastrophic life-threatening bleed. If you understand the science and the biologic rationale and the data, honestly, if you take a step back, why are you using red cells, plasma, platelets for that child who's massively bleeding? I mean, the data is not there. Right? We are doing our best to collect that data and to publish it and design trials to study it. But in the U.S., there is a fairly quick transition, when it comes to practice change, to using whole blood in hospital for life-threatening bleeding, pre-hospital, where most of the deaths occur from hemorrhagic shock, See, in the hospital, like hospital providers don't realize, 80% of patients that die from bleeding, it occurs before they even get to the hospital.
Yeah.
So if we want to improve outcomes for hemorrhagic shock, we got to put our sights in the pre-hospital phase of resuscitation, and we have to work a lot more closely with our EMS colleagues to improve practice in the pre-hospital space and to improve their access to blood instead of crystalloids, right? Which is what they mainly have. Roughly 70% of helicopter programs in the U.S. have a blood product available. It's not all whole blood, but at least they have some blood, whether it be red cells plasma, or whole blood only. But only 2% of ground ambulance systems have blood products available on ambulances. Now, if you think about it from a logistic perspective, it's much harder to stock whole blood in 30 ambulances in Pittsburgh, right, compared to 2-3 helicopters in Western Pennsylvania. But the ambulances are picking up the majority of those patients dying of hemorrhagic shock. We have to work on ways to make that more available. And we are. And there are limitations, but there are ways. But to answer your question, there's been a transition with the implementation of hemostatic resuscitation to use more whole blood over time. It is, I would say, the thing that's slowing it up the most is the availability of whole blood from suppliers. And that's a whole other dynamic to get into if you want to.
How do you see it as best first utilization of whole blood by perhaps a children's hospital? Do you see it as being the first cooler in that patient who's getting a massive transfusion? Do you see it like really targeting the trauma bay and the OR? Where do you see like the first step would be for maybe a blood bank system that wanted to get this going?
All politics are local. All medical practice should be local. You need to figure out in your institution, where is the life-threatening bleeding occurring the most, right? Usually in the emergency room, but there are certain operating rooms or cardiac ICUs. If you have a huge ECMO program, if all the ECMO patients come to one ICU, for example, right? I've worked in places where ECMO is in 5 different ICUs and it's split up. I've been in places where it's all in one. So the whole blood should be placed in emergency release refrigerators where life-threatening bleeding occurs the most. And it can be done incrementally, right? You start where it is needed first, and you learn from how to use it. When not to use it, there always needs to be a strong, QI process implemented when you bring in something like this to prevent overuse. The shiny new product phenomenon needs to be tempered. You go only for severe bleeding, and if you're using it inappropriately, that needs to be stopped. But that would be my approach. Put it where you need to use it. Strong QA processes to prevent inappropriate use. But I think, especially if people are listening to this podcast and blood bankers that aren't familiar with the data, can we focus on that? Because I'm afraid people will hear this and go, well, like, what's the data behind this? There's just because it's being used doesn't mean it's the right thing to do. So when you think about the biologic rationale for whole blood compared to individual components, because you have to think about, well, what's the alternative therapy? Like, what is the current standard of care? And the current standard is basically a 1-to-1-to-1 combination of platelets, plasma, and red cells. I don't think anybody's going to really argue that the current standard of care is the old school crystalloid-based red cell and lab-based plasma platelets, right? So if the comparison is whole blood to individual components, whole blood is a more potent product because there's much less anticoagulants and additives in that one 500 ml unit of whole blood compared to combining red cells, plasma, platelets, when combined has 3 times the volume of additive solution with citrate, right? And it's about 660, 680 mLs of product. So it's a more dilute product. So if you are in hemorrhagic shock, you're anemic, you're coagulopathic, thrombocytopenic, you want the therapy that's more concentrated, right? That's going to be more effective. It will be more effective than the diluted one. Whole blood is stored cold in the U.S. for civilian use. Therefore, the platelets are stored cold. When platelets are stored cold, they maintain their energetics. They have better hemostasis. We've known this since 1973. This is not a secret in the transfusion hematology world, okay? So the platelets are going to work better in whole blood compared to components where they're stored warm. And by day 4-5, you look at the aggregometry data, those platelets barely function at day 4 or 5 when they are typically transfused. It's safer when you use Group O whole blood, which has become the standard because from an inventory perspective, collecting only from O donors and stocking only O minimizes waste, and O is a universal donor, right? So you can give O to anybody. When you use a Group O whole blood product, it is safer than using components because when you use components, while you start with O red cells, they always transition to type compatible red cells, right? That's why they're always demanding those two ABO screens so they can start to give non-O red cells. Well, human error can lead to a fatal hemolytic reaction, and that occurs 1 in 80,000 transfusions. There's a risk of that with components. There's no risk of that with Group O whole blood because it's Group O red cells in the Group O whole blood. It's also safer because the platelets are stored cold, or it's a cold product with whole blood. With components, the platelets are at room temperature. You store platelets at room temperature, bacteria likes to grow at room temperature. So there's a 1 in 5,000 risk, right, of bacterial contamination. Now, the FDA has come out with mitigation strategies to reduce that risk, either by requiring pathogen reduction or large volume delayed sampling of those platelets to reduce that risk. But regardless, it's still a room temperature product that has a risk of bacterial contamination, and that can still occur at times. So whole blood is safer, interestingly. Okay, and then the advantage that is so hard to quantify, but is real important, are the logistic benefits of whole blood compared to components. You've resuscitated patients with hemorrhagic shock. Getting that blood from the blood bank, right, takes time. Getting it into the patient takes more time. Coordinating, have they gotten the red cells, the plasma, the platelets, has what's come up, what's been given, it's chaos. If the blood bank only has to give you one product, here's 6 units of whole blood in a bucket. You get 6 units. You just give 6 units, right? You don't have to worry about what's been given yet. Pre-hospital, helicopters, ambulances, even giving red cells and plasma together is a logistic hurdle. One product on a helicopter ambulance is way easier and way faster to give, right? And we all know time is money here. So whole blood compared to components can be given a lot faster, a lot more efficiently, can be given to you more efficiently. We think those reasons are why well-adjusted retrospective data and now prospective observational adjusted data is all supporting whole blood compared to components when whole blood is just part of the resuscitation, is associated with improved 24-hour mortality and in some studies 28, 30-day mortality. Christine Leeper, a colleague of mine here at Pittsburgh, published a meta-analysis of retrospective and prospective observational studies that were adjusted. In this meta-analysis of 24 studies, adults and children, close to 60,000 patients in this meta-analysis, a strong association with 24-hour survival and 28-day survival in the entire population as well as children and adults. This is not RCT level data. I'm a clinical trialist. I get that. But tonight, if you have to resuscitate a patient on ECMO with life-threatening bleeding and the pressure is 40/20 and there's blood is hitting the ceiling, what should you do? Is your standard practice based upon any evidence? Is your 1-to-1-to-1 based on any data? The answer is no. Right? When we went to components in the 70s and 80s, we did it out of logistic benefits for cancer patients who needed one product at a time. There was no evidence to support the transition from whole blood to components. So if you take the biologic rationale of whole blood, the safety aspect, consider that the standard of care has no evidence base to support it. If it was your decision and you had the ability to choose one or the other, what would you choose?
Yeah.
It's intuitive, yeah.
So that's why we're seeing a change. We all want trial data to assess efficacy and safety. And there are multiple trials that have been started in trauma populations. We are gathering the initial data for non-trauma populations too. But this whole question of practice change, is an interesting one. And in the ICU, we make this decision all the time, right? The indication for ECMO has been changing over the past 20 years. Right? A child with cancer would have gotten ECMO 20 years ago. Now it's inappropriate to not consider it. But there was no trial in stem cell transplant patients for ECMO. We just looked at the data, the pros and cons, and the standard of care, and we made a practice change, right?
Oh, yeah.
Why is there such resistance with blood products?
Yeah.
Because we don't control the blood. It's got to come from somebody else, right? And then it's the economics of the blood supply. And the problem with the supply is that the whole blood donors, right, when they go to the Red Cross, Vitalant, New York Blood Center, they have to decide what do they do with that whole blood, especially from a type O donor, okay? If I'm actually, I am type O positive. When I go to Vitalant or the Red Cross, they say to me, well, all right, we can either do a whole blood collection and make 1 unit of whole blood out of it, and then either fractionate it or keep it as whole blood, or we could put Phil on a red cell pheresis machine, and we can get 2 units, 2 donations out of Phil, right, of O positive red cells. What do you think makes the most money? 1 unit of whole blood, 1 each of components, or 2 of an O red cell, right? Pick C. Always pick C. Yeah. It's a third, right? So what do you think they do?
The latter, of course.
And then they say, oh, there's just not enough O donors around. We would love to make, Phil, I would love to make more whole blood, but I can't.
Yeah.
Why can't you? Because you were diverting the O donors for red cell production because that's economically most advantageous. Now, I get it. You have to make money. But there's this balance that I feel is not occurring, or at least we're not being told transparently that this is an economic decision. Stop telling me you wish you could do it, but there's just not enough donors around, okay? There's about 12 million whole blood donations per year in the U.S. That doesn't count the red cell pheresis that's occurring, right? 12 million donors, 40% of people are group O. Let's just call that 5 million whole blood donors that are group O, okay? Those 5 million group O donors could be making a lot more whole blood, but they're not. So this situation where the main barrier is supply. The suppliers all say, I would love to make more, but I can't. We got to start putting pressure on them to say, we get it. We know this is a business. There needs to be some balance here, but you need to stop making so many O red cells because who are they being used in? Bleeding patients.
You don't have a type and screen ready, yeah.
Why not just use the whole blood for them instead? And then you think about, there is data strongly suggesting when you use whole blood, you use less total blood. It is a blood management tool, right? We showed in data from St. Louis in adults, in the first 3 days of resuscitation, there was 2 liters less of blood used.
Wow.
2 liters.
That's huge.
Less of blood when whole blood was used as part of the resuscitation compared to components. I've said whole blood is part of a resuscitation a few times, and that's because most centers don't have enough whole blood to make it 100% of the resuscitation. So it's usually limited to 6 units, 8 units, 10 units so that everybody can get a little bit of it, right? And there's good data to show, and we've published it in adults and children, the larger the dose of whole blood, the larger the proportion of whole blood to total blood use, the better the outcomes and less total blood that is utilized. So again, why are group O donors, for whole blood donors, why are you making an O red cell out of it? Because that's going to now be used with components. That's going to lead to more blood being used when you could have kept it as a group O whole blood product, an Rh negative or positive, and it just doesn't make sense. Clearly the suppliers don't like it when I say this. I get a lot of hand waving and you don't know what it's like, but I'm saying there's a balance.
Yes.
And getting back to how do you affect change, like we as a community need to start going, well, we need you to be more responsible. The problem is you don't have a national blood supply system. If this was the UK, if this was Norway, if this was any other country with a national health system, we could affect this change. But it's a business in the US and it's much harder to control.
Oh, absolutely. And getting all of those priorities to align.
So I just want to make it clear that this interest in whole blood is not without evidence, right? It's not without a rationale. It's not without thinking about it academically.
Yeah.
And we have to make the best choices for our patients today. And we shouldn't be limited to say, well, I'm not going to make a change without RCT level evidence, right? Because you hear that all the time and people play that card when they just don't want to make change, right? Because for them, there's some other reason that they don't want to do it. And because we make change all the time. We want RCT level evidence. Again, I'm a trialist. This is what I do for a living now, right? So I'm supportive of doing trials to change practice. but I don't think it's mandatory. And we have to start having that conversation transparently when it comes to hemostatic resuscitation. I mean, there's a great quote by Maya Angelou that says, do the best you can until you know better. Then when you know better, do better. Right?
That's great. Yeah.
And we need to implement that when it comes to hemostatic resuscitation and get our transfusion medicine, blood banking colleagues to understand that.
Oh, absolutely. And I will say, we prep for this episode. You could PubMed you could PubMed Dr. Leeper, you could PubMed the topic, and you will find a body of work. I want to ask a very logistic question. Now, you mentioned sort of the chaos of during massive transfusion, your nurse is hanging blood, and then they've given one, and then they're trying FFP. This. The other thing that's happening there often is that the calcium is dropping. You're trying calcium gluconate. The patient's hypotensive. You're lining the kid. You're getting calcium chloride. Does whole blood, does it tank the calcium in the same way?
Yes.
Okay.
I just learned something about this 3 days ago. So the amount of citrate in the whole blood unit is equal to the amount of citrate in the 3 other bags, red cells, plasma, platelets. Because when whole blood is collected, there's a certain amount of citrate in that whole blood bag. And then that is fractionated, so the amount of citrate in the parent bag is just distributed in the 3 other bags, unless, this is what I learned, it's stored in additive solution number 3. There's multiple additive solutions, CPD, CPDA1, AS1, 3, 5, and now there's 7. AS3 has additional citrate. AS3 is used within the U.S., but not super common. So citrate is equal, the quantity in a whole blood unit compared to the 3 components, unless you're using AS3.
Yeah.
But the additive solution, right, is triple in the 3 components compared to the whole blood unit. So the calcium chelation that's going to occur from citrate will be similar in the 500 ml unit transfusion versus the 680 or so ml volume in the components. So monitoring for hypocalcemia is very important. In every MP protocol I've ever written, I've always required standard labs being done over time to monitor not only calcium, but potassium, et cetera. And I don't say you wait for your labs to give blood products, but your labs do tell you where your resuscitation has been to kind of at least know for potassium and calcium you're having issues. The controversy comes from the concept of pre-hospital empiric use of calcium. And that gets tricky. I think, conceptually, you want to avoid hypocalcemia for multiple reasons. Not only does it improve myocardial contractility, right, to improve cardiac output, O2 delivery, it's a cofactor in hemostasis. It also helps with endothelial permeability, reducing it. But willy-nilly calcium could also be harmful too. And I just think we got to be a little bit more careful about not going overboard with empiric use of calcium. In the pre-hospital space, I think if a patient already got 2 units and they've been bleeding a lot, they're consuming calcium, I would give it. In a child, what does that mean? 30, 40 per kilo? It's really hard to make those comparisons. So that's my thought on calcium.
Oh, thank you. Now, something you mentioned was the temperature of platelets and how maybe they're warm now and they used to be cold and they worked differently. Can you explain this further?
Yes. So up until the late 60s, early 70s, platelets were stored cold because that's how whole blood was stored. We learned how to take platelets out. We put them in the cold, but just for 3 days. That was the standard back in the 60s. A study was done, published by someone named Murphy, 1969, where they did a study in healthy volunteers and showed that a room temperature stored platelet circulated in the body longer than a cold stored platelet did. When you store a platelet cold, it does activate the platelet. When it's activated or primed, it gets pulled out of the circulation faster. But it's primed, like it's ready to do the work. In this study of healthy volunteers, because they found a room temperature platelet will stay in the body longer, they said their conclusion was cold stored platelets should be abandoned for clinical care as a result, because the main customer are oncology patients where they're using platelets to prevent bleeding in the future. So the concept was, all right, well, if it stays in the body longer, it's going to be more efficient for prophylaxis. It's also going to lead to less platelet exposures, to lead to less antibody formation and platelet refractoriness, right? So to reduce exposure to patients, we want them to circulate longer. they'll need less platelets, they'll get less refractoriness. But we knew. Aggregometry data, bleeding time data all showed a cold stored platelet was more hemostatically active. So we prioritized circulation time over hemostasis because 66% of the patients getting platelets were oncology patients. And the community said, we don't want a double inventory where we keep cold platelets for bleeding patients and we keep room temperature for prophylaxis. People that were around back then say in retrospect that's embarrassing. They should have went to a dual inventory system, but they didn't. We went down this pathway of, we call it the transfusion medicine dark ages, where we kept platelets at room temperature from the 70s up until 5-8 years ago. And when you look at a room temperature platelet, is it going to prevent bleeding or stop the bleeding well prophylactically if it's in the system but doesn't have any hemostatic capacity left? When you store it at room temperature, the energetics of the platelets continue, and it winds up using all of its energy, in a simple way. So it doesn't have anything to give on day 4 or 5. So it's circulating, but it's not going to do the job. And people think that's why the trials of platelets are showing more harm than good. Because when they're given, it's stored at room temperature. The Planet 2 study in NICU babies, right? There's adult hemorrhagic shock study, or even the Plato study that looked at different doses of platelets. One wasn't better than the other because we might be using a room temperature stored platelet that doesn't work. There was this misguided decision in 1969 for survival and recovery studies in healthy volunteers that led us down this path. And we are now reconsidering, right, and using cold stored platelets for patients with active bleeding. But maybe for prophylaxis, we shouldn't be using room temperature stored platelets either. So I've said healthy volunteers a few times on purpose because if we've looked at the literature, in 1973, there was a small trial done by Becker and Astor where they looked at cold versus room temperature platelets in adults on aspirin and those with cancer, adults and children, that were thrombocytopenic. Okay, and they did a randomized trial, cold versus room temperature platelets. And interestingly, the cold stored platelets in these thrombocytopenic patients circulated longer than the room temperature. And I read that literally 6 months ago going, holy shit. Not only did we have a misguided decision, it was based upon data in the wrong patient population. Mm-hmm. We've translated data from a healthy volunteer population instead of looking at the critically ill thrombocytopenic patient, that them bleeding or not. And for some reason, and I can't explain it today, but in a thrombocytopenic patient who may or may not be bleeding, actually the cold stored platelet had a better expected platelet rise than room temperature. So why are we all saying room temperature should be saved for prophylaxis? Myself, Andre Kapp, and a collaborator, Maurice Stola, out at Bloodworks in Seattle, we've just designed a trial submitted for funding to study cold stored platelets in oncology patients, whether they're bleeding or not. So we plan to study this for both prophylaxis and bleeding for adults and children with thrombocytopenia who are at risk of bleeding, who are bleeding, that have oncologic disorders, mainly leukemia or stem cell transplants. But there are many places using cold stored platelets now. We are incredibly close to finishing our CHIPS trial. CHIPS is intended to license cold stored platelets out to potentially 21 days. It's a study being done in 1,000 children and adults with actively bleeding cardiac surgery patients. We're up to about 940 patients now out of 1,000.
Oh, wow.
So we think by March we should be done recruiting. Middle of May we'll have results. And we'll know by May, June if a cold stored 21-day platelet is at least non-inferior to a 5-day room temperature. And we're doing statistics to also evaluate for superiority. We use an adaptive trial design to look at multiple maximum storage ages of the cold platelets. And we're hoping to be able to report at what storage age is a cold stored platelet superior to room temperature, and also at what storage duration is it non-inferior, because that matters. You want to know when it's superior, so you can change practice to use a better product. But what if you're out in the Hamptons, out on Long Island?
What if we're out low resource? By many regards.
I was just thinking Long Island. Like the Hamptons are as austere as it gets out there. Out
you are a long drive from a trauma center. That's all I'm saying.
That's my point. Or anywhere upstate New York or middle of Pennsylvania. If you don't have platelets available today, you would take a 21-day product that is non-inferior to room temperature platelets because at least it's doing something. right? Because you might not be able to afford, let's just say 11 days. I'm just making a number up, is the storage duration at which cold store platelets are no longer superior. You might not be able to afford to maintain cold platelet out for 11 days in an austere environment, in a low-resourced environment, right? So we're excited about the CHIPS trial data that we'll be starting to, present on the lecture circuit May, June, July or so. Dried plasma is something else that we need in the U.S. for civilian use. Dried plasma is a great bridge to care, definitely in the pre-hospital space, and especially currently when whole blood is so hard to resource. If you can't get that, at least use dried plasma. There is good RCT level evidence published by Jason Sperry here on the adult side in Pittsburgh showing dried plasma pre-hospital does improve 28-day survival compared to standard care when it's used less or only basically a red cell crystalloid-based predominant resuscitation. So dried plasma needs to be licensed in the U.S. and it needs to be incorporated within the hemostatic resuscitation context. But the problem is going back to whole blood from components, we're just going back 100 years into what we used to do, which is probably better than components. That's kind of like our advancement was going back to what we did 100 years ago. That's not a huge advancement. That's like going from second gear to third gear. It's not super, and you were in third gear in the first place. How do we kick it into fourth or fifth? To do that, we have to be able to practice precision transfusion medicine. Give a specific patient specifically what they need at that time of their resuscitation. And the only way to do that is to improve our assays for shock, coagulopathy, endothelial dysfunction, immune function, to know at a specific time quickly what do they need to improve any of those deficits. And we don't have any assays that come anywhere close to telling us our oxygen deficit, hemostatic function, endothelial, we don't even know what to do. And immune function just takes too much time because if it's going to work, it has to be done within 5 minutes, 10 the most, right? So we have to partner with our bioengineers, right, to make more efficient assays that are rapid, that can tell us who needs better O2 delivery, right? Who needs an anti-shock drug, right? Who would benefit from reducing their metabolism? Who needs more platelets? Who needs fibrinogen? Who needs a PCC? Who needs plasma for endothelial protection, right? Who needs an immune stimulator? Who needs GM-CSF, a Mark Hall type study, to improve their immune paralysis, right? We're not going to improve outcomes past where we are now to a big degree without making that next step. You can't make that next step without the assays to inform precision transfusion medicine. And even TEG-ROTEM, I've been talking about viscoelastic assays for 20 years. I think they're good. They're not the answer. It's better than a platelet count. It's better than a fibrinogen function. It might help slightly incrementally, but it's not the ultimate answer. We need something better. And potentially the work in the multi-omics space that is telling us different endotypes of patients that may be able to tell us why, Zach, you're different than Alice and why I'm different. And that a rapid turnaround time for an omics-based assays that can determine your endotype might be able to tell you, you know what, Alice, you need more fibrinogen because your fibrinogen does not do well when you're injured.
Alice and I get the great pleasure of speaking with people, experts in all various fields around pediatric critical care. And I feel like the theme that is most central to every discussion we have is that there's a desire for precision in critical care, to know more information about that unique patient, be able to adapt our therapy to it. And it's not surprising to hear that this will be a major focus moving forward in transfusion medicine and resuscitation. As we wrap up our conversation of cutting edge transfusion thoughts, there's some emphasis, some focus, some conversation around using plasma, fresh frozen plasma, as a volume expander, maybe even outside of the massive transfusion space. We think about crystalloids maybe contributing to endothelial dysfunction and fluid overload. Will you tell us what is the cutting edge in using plasma in this way?
Sure, of course. It's a topic that I've been very interested in pursuing, and many others have been interested in pursuing for the past 10 years or so. So we should go back to why we stopped using plasma as a volume expander. It was the volume expander used in the 50s, but because back then plasma was pooled and we weren't clearly doing transfusion-transmitted disease testing back then, it led to millions of people getting hepatitis as a result. We didn't know it was hepatitis B, C back then, but there were millions of patients with hepatic failure and dying, and they traced it back to the plasma. So because of that, right, the safety risk of plasma, not the efficacy concern, but the safety risk, guidelines were developed and standards were developed that said, and they still do, plasma shall not be used as a volume expander, right? It's one of the main laws of transfusion medicine. You shall not cross that line. And it's because of the safety risk, and that safety risk was huge. Interestingly, back in the early 70s, up to 23% of patients getting any blood product got a TTD. Think about that, right? And since the 70s, we've gotten a lot better with all of our blood products and screening for hepatitis, HIV, HTLV, et cetera. Now where it's like, 1 in 2 million, right? But we forget, and in the blood bankers, they haven't forgotten that the history was a tremendous amount of TTD risk. So with plasma, they remember it, and it's very hard to cross this line. But as I just mentioned, with nucleic acid testing, and now even with pathogen reduction, that pretty much virtually eliminates any risk of a TTD, we should reassess. Just like in a resuscitation, right? There's an intervention, you reassess, right? Intervene, you reassess. Well, with plasma, the intervention was NAT testing, pathogen reduction. We should reassess its use as a volume expander. Because if you think about it, compared to crystalloids, right, there's a tremendous amount of data showing plasma definitely stays within the intravascular space much better than crystalloids do, right? There's good data on that. So if it stays intravascular, it improves preload. Improves preload, improves cardiac output. Improves cardiac output, improves O2 delivery. What's the main problem with all of these critical illnesses? O2 delivery and shock, right? These are shock-generated conditions in general. So the intravascular volume aspect or the volume repletion aspect of plasma over crystalloids has that as a mechanistic basis. Taking it a step further, patients in shock develop endothelial injury. That endothelial injury leads to inflammation. Crystalloids strip the glycocalyx. It's a very acidic product. If you strip the glycocalyx, you lead to more endothelial permeability, more inflammation. With plasma, it might be because it's just not crystalloids. The good part about it is that it's not the other thing. Plasma seems to maintain endothelial health. The glycocalyx is not stripped. Actually, there seems to be some regrowth of the glycocalyx with plasma resuscitation. So now it's actually less inflammatory. Plasma is less inflammatory than crystalloids. I know there might be 1 in 1,000 bradykinin type reaction in some patients, but across the general population, plasma is less inflammatory compared to crystalloids. Data to support that too. For patients that are critically ill, that are inflamed, they become hypercoagulable normally. If they become severely bleeding, now they become hypo. But usually our septic patients, our critically ill patients, ARDS, they're in a hypercoagulable state. Crystalloids early, a little bit of crystalloids, will actually, through inflammatory pathways, make them even more hypercoagulable, right? Diffuse microvascular thrombi formation, the whole Joe Carcillo pathophysiology and badness, reduced organ perfusion, organ failure. If you give a lot of crystalloids, you can dilute them and then make them hypocoagulable, increase the risk of bleeding. Plasma is a neutral product. We all think of plasma as procoagulant. Protein C, protein S, antithrombin. It is neutral. Okay, so if you give it to a hypercoagulable patient, it actually can make them more normocoagulable. It provides hemostasis, homeostasis. Okay?
Nice.
So you have the improving shock by improving cardiac output. You reduce inflammation. You normalize hemostasis, and there's endothelial protection too. So again, why in the world, for a patient in shock, are we using a crystalloid-based resuscitation instead of the ultimate balanced fluid, which is plasma? So we've designed a trial and for patients in septic shock where we will compare plasma to crystalloids, and we're hoping to start that here in Pittsburgh within the next 4 to 5 months. It does require exception for informed consent to do this. The logistic aspect of this trial is quite tricky because we need to have plasma immediately available, right, in the emergency room. But we've been able to figure that out here in Pittsburgh, and we're hoping we're going to start in adults, transition it to children, and that might be the future, especially when dried plasma is licensed. Now you can have your vial of dried plasma anywhere in your hospital. Put it in your Pyxis system, right? Type AB plasma, even type A is probably safe enough to be used as a universal donor. And plasma will be the ultimate in this balanced fluid conversation.
So exciting.
So blood products are not only good for bleeding patients, it may be better for volume resuscitation too, since we've made it a much safer product, especially with pathogen reduction.
Yeah. So it's clear to see there's so much excitement in whole blood, cold platelets, plasma, so much to keep focused on as we watch the literature come along. We really appreciate your time sharing all this knowledge with us today, sharing the experience. This conversation really had it all, from just a story of one's own journey to what is old is now new again. And as we look forward, all the excitement that we have coming to help inform better how we can.
And you relearned a little bit about Machiavelli too.
That's right. Yes, we haven't had the arts. The arts. You're thinking about our audience of critical care fellows, critical care attendings, and all those people who take care of critically ill children. Anything else that you'd like to mention before we wrap things up?
Yes, you asked me what my passion was outside of work, and I said cooking.
Yeah.
When it comes to making meatballs, okay?
Yes.
The trick is fresh basil. Do not use fresh basil, and use a lot more eggs than you would imagine. Okay, that's all. That's the only. I'm not going to give you the full secret.
Right.
But experiment with more eggs in the meat and fresh basil, and you'll get there.
And this is a 1-to-1-to-1 ratio, I'm sure, right?
I'm not.
No,
I'm not telling you
told
that.
us the recipe.
I'm not telling you that. Sorry. If I told you that, you would need whole blood.
Well, Dr. Phil Spinella, thank you so much for joining us today. This was so good.
All right. Take care. Thank you very much.
And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. It's also worth noting that the views expressed during this episode by me, Zach, and our guests are our own and do not reflect the official position of our institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com. If you want to help support the production of PedsCrit, you can find us on Venmo and Patreon. We've also had some light merch made in the form of PedsCrit laptop stickers. And if you include a mailing address with any contribution, we would be so excited to send you one. Thank you again for listening.